Representative Simon.
Thank you, Mr. Chair, and I'll be brief. Just very quickly for Dr. Petro? Petro, I'm sorry. If you could just explain to me maybe the difference between a patient getting a THC capsule as opposed to smoking marijuana. Is there any difference in the benefit that the patient would receive from that?
Yeah, actually, when I had submitted my proposed study to the FDA, at the time I was even an FDA employee in the middle 1970s, and working also at the Hershey Medical Center, I planned to use cannabis rather than THC, but the government stated that this essentially would be the sine qua non to prove whether marijuana worked. In other words, if the most, quote, dangerous toxic component of cannabis worked, then you would suggest that marijuana works. So this was in fact a drug that was used. This is much less effective than inhaled cannabis. I'll just give you briefly 2 sentences. If you are a patient that has the nausea of cancer chemotherapy or intractable muscle spasms, you need immediate relief. If you inhale marijuana, the marijuana is in the brain, in these receptors, not in the area that's the dangerous part of the brain, but in the pain-sensitive areas, within 1 circulation time. That's 17 seconds. You reach the maximum drug level in the brain within 7 minutes after inhaled marijuana. With this, it's between 1 and 2 hours. So it's much more effective in certain pain syndromes where there's a sudden onset of what we call lightning pains to have a treatment that's fast and effective. And I also might remind you that in comparison to the opioids reach peak level in periods of half an hour to 2 hours. And in fact, in Europe right now, there's a major concern because of the passive euthanasia problem. Sick patients with cancer and ALS and other neurologic diseases are actually sequestering, they're secreting drugs like Vicodin, etc., to use to commit suicide. There's no way you can commit suicide by inhaling marijuana.
Thank you for your testimony. Thank you,
Representative DeGerone.
Thank you, Mr. Chairman. I'll be quick, and thank you, gentlemen, for being here today. And just real quick, I'm curious about your report back in 2000. Is there any way you could submit that report to the
And
committee?
I think you might find the other one, the 300 diagnosis, because we used a PhD statistician and physicians and all on that committee for that. It's distressing that we see it was good for prevention. We're looking at barriers, but I'll submit both to you, sir.
Yeah, I would really appreciate that. And
My pleasure.
I noticed you had 69 professionals responded to your
It's
questionnaire.
not a good sample. It's not, for me, a good sample, but that's why I'm hoping now with the use of the internet. The last one went out as part of a newsletter with a link written on the bottom. It was an electronic newsletter, a lot of which just got deleted. The 25 that did respond right away were in favor. But I want to get the full mailing list in PCB to put this out again and have a 400 respondent database because that would be, there's about 400, maybe 500 or so out there. I want about an 80% response to legitimate research.
Okay, thank you. Thanks again for your good work.
Representative Benningham.
Thank you, Mr. Chairman, and thank you both of you gentlemen for taking time to share your insight and experience. This is specific to Dr. Petro. Just in case I'm missing something, are you currently practicing physician in Pennsylvania?
No, my last practice was in Washington, D.C. I moved to Pennsylvania for personal family reasons, and I've limited my work to consulting with people interested in drug development. And
I only went to 2002, 2003, and I maybe I was missing a page because some of them were upside down. I just want to clarify that.
yeah.
And the reason I ask that is
Actually, I applied for a license in Pennsylvania, and to be honest with you, it was not financially, it's not viable because of the malpractice issue in the state, but that's a different issue.
yeah, that's a discussion we could have for a long, long time. One we'd like to address, some of us anyway. Actually, the reason I asked that is one of the concerns I have in any of these type of discussions is generalizations. In your comment in paragraph 2, you state marijuana is recognized by the medical community as a safe and effective in treating pain. And I'm just interested in qualifying who that medical
wide term.
Actually, at a meeting in Toronto, Canada, of the American Academy of Neurology, probably 20-some years ago, there were maybe 500 to 600 neurologists in the room, and I gave my essential review presentation, obviously a scientific presentation. And at the end of it, just out of curiosity, I had a show of hands, especially oriented to those that didn't agree with the position that, in fact, there was a role for cannabis. Out of the 500, there might have been a dozen docs who raised their hands objecting to my contention. Again, maybe a dozen out of 500. Now that's not a sample. Just to give you an example of the widespread use of cannabis among MS patients, there's 350,000 MS patients in the United States. People have done surveys to look at numbers of patients who are using cannabis today. It's probably somewhere between 10 and 20%, so it's 70,000 patients every day are using cannabis to treat the severe spasticity or muscle spasms or other symptoms associated with it. But in terms of getting direct evidence about that, it's difficult because of the legal, conundrum. It's the catch-22. I have a slide normally that shows that paragraph from catch-22 where Joseph Heller describes, flying over Germany and essentially how you can get out of flying these raids. And you can essentially say that you can study delta-9 THC to death as a Schedule III drug, yet marijuana, which is by any estimation safer, is in Schedule I. It just doesn't make sense. And remember, it's 2009. Marijuana still is in Schedule III. Marijuana is in Schedule I. Marinol is in Schedule III. Makes absolutely no sense.
I wouldn't argue that, but I just want to clarify again that the statement that recognized by the medical community comes from that conference that you're in Toronto. And what year?
No, well, again, the basic science and the clinical science support it. An animal study supports the fact that it's effective. Like I say, how can you get the animals to fake efficacy?
Okay, but I want a definition. I don't mean to give you a hard time, but just for my lack of knowledge, because I'm not a physician, of who you're defining as a medical community, because that's a pretty bold
This would be,
statement.
okay, obviously this would be neurologists, oncologists who treat the nausea, cancer, chemotherapy, etc. Now there was a survey, I don't have the citation, 60-some% of oncologists recognize cannabis as a viable alternative to conventional drugs for the nausea, cancer, chemotherapy. Well, that's at least a majority. You win an election with 60% of the votes. Certainly it's well over 60%, 50% as far as the neurologic community. But since, again, I'll give you a final look at this. I've presented this evidence maybe 100 times over the last number of years. I have yet to find a credible neurologist, a real doctor, to take the alternative point of view. Occasionally I'll have people who are involved with the criminal justice system who will do the reefer madness story about how, in fact, it's destroying America's youth, but I never get anybody to argue the science.
Well, we could debate this on and on. I'm not sure if we're really getting to the point of my question, but I think it is important that we do qualify these generalized terms as the medical community, and whether it's this year or 5 years ago or 20 years ago when you gave a presentation. Because reality is, and I heard an earlier physician say, whether or not he only wants to talk about the medical aspect of this, the legislation, should it move or not move, is going to be done in the political realm.
Sure.
And I think until we have science to back it up or disprove some of these things, it's going to be very difficult for many members of the community and those people that we represent to necessarily come out and endorse these types of things. So I think it's important that we don't talk in vague terms or about some conference I may have spoke about in years past, and I appreciate your candor on that.
Absolutely.
Chair, thanks, gentlemen. Appreciate your testimony. And if we could